Now for tonight's program, JOCO in the Know. The program is on the status of mental health services in Johnson County. I want to introduce our moderator and league member, Jill Quigley. Jill is a nurse with a master's degree, and she has worked as an outreach coordinator at Family Health Care, a safety net clinic in Kansas City, Kansas. In 2008, she was elected to the Kansas House of Representatives. Jill served in the House for 3 years and counts the statewide Clean Air Act as their greatest accomplishment during her term. Jill continues to be an active community volunteer, serving on the boards of United Community Services of Johnson County and Oral Health Kansas. Jill is a founding member of the Giving Grove, a new nonprofit involved in planting fruit and nut trees for the hungry in the metro area. Jill will introduce our panel.
Good evening, and thanks for getting out on such a cold, rainy night. I appreciate it. We have kind of an intimate group, so hopefully we can have a good discussion. Before we get started, I want to just cover a few housekeeping things. There is a restroom. You come up the ramp and go through that door right there. Restrooms are there. In the back, there's food, and there's also a lot of information on the tables back there, including there's one article that you might want to pick up on your way out. It's a nice summary of mental health issues written last August, so it's fairly current. Very nice article. And I want to take a minute to recognize the members of the committee that worked to put these forums together. It's the League of Women Voters of Johnson County Government Committee. Sandy Sanchez is our chair. We also have Candy Birch, Roberta Eveslage, Terry Huntington, Ade Negrete, Mindy Reed, Sue Storm, and Missy Taylor. If you're here, ladies, raise your hand. And thanks, ladies. And finally, if you would just take a few minutes to check your cell phones and make sure they're turned off so that we don't interrupt our speakers. Tonight we have a very knowledgeable and diverse panel to talk to us about mental health services in Johnson County. This is Johnson County in the Know. The forum is entitled The Status of Mental Health Services in Johnson County. Probably many of us have kind of a vague understanding that money has been cut to mental health services, but we probably don't know the details surrounding that. And hopefully, after listening to the panel tonight, we'll have a great deal more detail that we know about. Tonight, our panel includes Jason Hess, who is the Executive Director of the Heartland Regional Alcohol and Drug Assessment Center. Currently in his 20th year in the substance abuse field, he has a long history of providing alcohol and drug assessment, treatment, utilization review, and clinical supervision. Jason is a licensed clinical addiction counselor in the state of Kansas and holds a master's degree in clinical psychology. He's been employed by Heartland RADAC for 17 years. Jason? Tim DeWeese is the new director of the Johnson County Mental Health Center. The Mental Health Center is a department of county government employing more than 340 staff who provide behavioral health services to more than 9,000 county residents annually. Tim possesses a Bachelor of Science degree in psychology from Missouri Southern State University and a Master of Social Work Administration degree from the University of Kansas. He's a licensed mental health professional in Kansas and has over 25 years of experience in community mental health, where he's worked in various capacities. He possesses extensive knowledge and experience in the mental health delivery system, psychiatric rehabilitation best practices, client-centered leadership, and program design and development. He served more than 10 years as a commissioned officer in the Army Reserve and National Guard. He and his wife have lived in Johnson County for 20 years. Deb? Kyle Kessler is the Executive Director of the Association of Community Mental Health Centers of Kansas. He graduated from Emporia State University with a double major of history and political science, and then received his master's in public administration from Kansas State. He was a deputy secretary in the Kansas Department of Social and Rehabilitation Services, the old SRS, which is now the Department of Children and Families. And then he moved to KVC Behavioral Health as their executive vice president in charge of public affairs. He and his wife, Mindy, have 2 daughters and live in Topeka. Kyle? And finally, Sharon Manson has worked with children with emotional disorders and mental illnesses in the Shawnee Mission School District for the past 35 years. In that capacity, she's worked directly with children, teaching them social skills and coping strategies in order for them to manage their emotions and become successful in the school environment. She also works with teachers and other school personnel, helping them to understand the struggles students with mental illnesses face. Together, they develop a supportive environment so that students can thrive in the school setting. Sharon is also a member of the National Alliance on Mental Illness, or NAMI. That's the way you say that, Sharon? NAMI? NAMI. She joined NAMI in an effort to better understand and support a younger sister who struggles with bipolar disorder and borderline personality disorder. Through NAMI, she has gained a better understanding of her sister and found ways to help support her. She has taught NAMI's educational program, Family to Family, which is designed to help family members cope with the mental illness of loved ones. She currently leads support groups for people who have a family member dealing with mental illness. We will do things tonight is we'll let the panelists speak one by one for about 10 minutes. They'll tell you a little bit about their organization, and then maybe some successes or some concerns that they have. And then we'll open it up to questions. There will be someone circulating with cards and pens. If you have a question, raise your hand. They'll get you a card. You can write your question, raise your hand again, and they'll bring it up to me. Then when it gets pretty close to 8:30, we'll ask them to make some closing comments. Would you like to start? Sure. Start on this end and move across.
Really what I want to do is put the microphone in front of Tim and let him do all the talking tonight. Can you hear me okay? Is it coming across at all? Is that better? Okay. Microphones and I never have gotten along very well, unless I'm talking to our staff, and then when you do that, you get people's attention really quickly. Heartland Regional Alcohol Drug Assessment Center, which is the agency that I represent, has been around in its form since 1998. As the name suggests, we're a regional agency. So we provide services primarily in 76 counties across Kansas. So if you take the western half of the state, chop it off, we're in a big portion of that. Our corporate offices are here in Johnson County, right down off of Shawnee Mission Parkway. And like I said, we provide services all over the state. Our primary mission is to assist people in accessing alcohol and drug treatment services when they need it, as they need it. And that's our hope always, is to be able to give people access to services. Over the years, we've increased our services from just helping people access, doing good solid alcohol and drug assessment, referral, getting people into treatment or rehab, whatever they might need, just developing those plans to help people get into the intensity of service that they might need, and also access to funding streams like Medicaid or for some other block grant funds that come through the state of Kansas. Our services increased to case management. We provide case management to families, folks that receive temporary aid for needy families dollars through the Department for Children and Families. We work with the Kansas Department of Corrections in 5 of the state prisons around the state. We work with parole and community corrections offices all around the state, working with DUI offenders in monitoring their clinical need after they've committed their 3rd or subsequent offense. And then along with that, we work with Tim's group, with other mental health centers around the state to provide what we call intensive case management services in several communities, Johnson County being one of those. Our hope with that population is that we can connect them to services, keep them out of the state hospital, keep them out of emergency rooms, and it's working with those folks who are very chronically addicted to alcohol or the drugs, have very significant mental health issues, are homeless or precariously housed or couch surfing, those kinds of things. We work with those folks specifically in Johnson County with some money we get from United Community Services. So the liquor tax dollars, we get some of those dollars to work specifically with the homeless in Johnson County who also have those same issues. And the hope that we always have when we're working with folks is connecting them to recovery-based services in communities. How can we make sure that they get connected and stay connected to mental health services? How can they get connected and stay connected to physical health services? How can we get them into housing that's going to allow them to stay a little more stable in the community, so that they're not living under bridges and they're not living in parks and things like that. Our hope really is that we can help people stabilize enough that their risk in going to jail, accessing state hospital, those kinds of things goes down. In addition, you wanted us to talk a little bit about successes that we've had, and I think that we have had some really good success over the years. You never want to say this too loudly, but sometimes when funding goes away, creativity increases. And about 5 years ago, the funding really dropped out of all of our systems. And it required that we get really creative really quickly so that people didn't drop off. And it hurt us pretty badly when it happened across the board. I don't care if it was mental health, I don't care if substance abuse, but what we're able to do is get creative, begin working a little bit more together to how we can integrate our services and make sure people's needs are met until the funding could slowly return. Now we're looking at funding quickly going away again, and so how can we keep doing that? One of the biggest successes we've had, and Tim would probably agree with this, in that we were able a year ago to enter into an agreement with Johnson County Mental Health and Wyandotte Center, Wyandotte Incorporated in Wyandotte County, and open up a program in the old Rainbow Mental Health facility called RSI, or Rainbow Services Incorporated. The purpose of that particular facility is to help people stay out of jail, help people stay out of emergency rooms, and keep them out of the state hospital. It's a place of, as Governor Brownback said in the press conference announcing the funding for that particular facility, is it's a port of calm, where police officers can pick somebody up who's high drunk and loaded, who's having an acute mental health crisis, drop them off and have somebody watch over them to keep them safe, get their medications reinstated, connect them with a case manager, and really try to avoid accessing those very, very costly services that are out there in the community that people are accessing. It's putting police officers back on the beat more quickly. And Heartland RADAC, in our little third of that particular project, operates a sobering unit, where folks that are intoxicated can come, be safe for 4 to 6 hours until their blood alcohol level can go down, have somebody with lived experience. We have people we call recovery coaches who are in recovery themselves from alcohol or drugs, talking to them the entire time they're there. So as the alcohol leaves their system and they become a little bit more coherent, we're talking to them about things don't have to be this way. You don't have to come back here. You don't have to go back to jail. We have services that we can help you access, and if you so choose, we'll get you connected to those. And that's really the purpose of the whole facility, is how can we get people reconnected in their communities so that they don't have to be put in expensive services like the state hospital and emergency rooms. And so we're about to be open for a year in April, which we're very excited about. The data that's coming out of that program is very encouraging. There are very, very few voluntary admissions to Osawatomie State Hospital out of Johnson County and Wyandotte County anymore. We have detox services that are being used more efficiently from substance abuse angle. We work closely with the adult detox unit that Johnson County has over off of Neiman, and so we're able to reconnect folks pretty well. As always, we've got challenges when it comes to the dollars that are paying for those services, and Randy Kallstrom with Wyandotte Inc. is looking for ways that we can continue to fund. Tim is out there beating the bush to how we can continue to fund and sustain those services, and that's becoming more and more of a challenge. We're clearly supporting any kind of push for Medicaid expansion within the state, as that will do nothing but serve us well in the future. And so, it will. What it really does is it increases access to services. From the substance abuse side of things, Tim and I were just talking about this. He asked what our Medicaid penetration rate is in the substance abuse field. It's less than 10%. Over 90% of the people that access substance abuse treatment that don't have resources to pay for it themselves are funded through public dollars. And those public dollars haven't increased to pay for services in several years. And so they're being stretched thinner and thinner and thinner. What that means is people have to wait longer and longer and longer to get into needed services. So capacity is unable to increase for treatment services because there are no dollars. If we had some expansion on the Medicaid side of things, the burden on those particular dollars would ease, and we'd have better access for services. People would be able to expand some of the treatment services that are out there, and those clients that we see, and we see roughly 7,000 people a year across our 76 counties. And sometimes we're looking at 6, 8, 10-week waits to get into a substance abuse treatment service. Anybody in this room that knows somebody who's in recovery, ask them sometimes if when they got sober, if somebody had said, no, you can't do it yet, you got to wait 8 weeks, what they would have said to you back then. They would have been out using again, and that's what we often see. It encourages a revolving door. So on that downer note, I'm going to turn it over to Tim so he can talk about what he does.
Again, my name is Tim DeWeese, and I'm the director of Johnson County Mental Health Center. I've been the director there since October, so roughly 6 months. And interesting enough, I've been with the county and specifically the Mental Health Center for 19 years. And so one of the things that I wanted to share with you, just a little bit of history, is that early on in my career, I learned that Johnson County Mental Health Center was the place that you wanted to come work if you wanted to make a difference in people's lives. And my first job I got was at a place called Comprehensive Mental Health Center in Independence, Missouri. And shortly, just there a brief time, and learned about how well supported by the community, how well supported by the county Johnson County Mental Health Center was, and knew that right then and there that was the goal, is I wanted to come work here and live here. And so I've been able to do that for 19 years. I will also say that the Johnson County League of Women Voters are at a central point with Johnson County Mental Health Center. Many of you may or may not know, we would not exist if it was not for the League of Women Voters. In the early 60s, before the Mental Health Act, the League of Women Voters saw the need in our community for treatment of the mentally ill, and they approached the county commissioners, and it was through that effort that the county commissioners established the Mental Health Center here in Johnson County. So there's a long history of supporting mental health services in Johnson County. And while we've experienced a lot of difficulties over the last couple of years within the Mental Health Center, I look forward to the continued support of the community and of the County Commission in helping us move forward. One of the things that I've shared with my staff in regards to my vision of the Mental Health Center is that I say that I want us to be the gateway to behavioral health services in Johnson County. I say the gateway, meaning that if a person needs assistance, they can come to us. We can assess them, and then we may provide services, but then we also can refer them to our community partners. There is way more of a need in Johnson County than the mental health center by itself could provide. And so our primary focus at the mental health center has been to serve those individuals who have serious mental illness, those youngsters that have a severe emotional disturbance, or those individuals who are in acute crisis and may need more intensive services, that maybe you're going to the ER or RSI or ending up in the state hospital. And so that's really our primary focus. And we've begun to develop a very good partnership with a number of providers in Johnson County that can help us meet the need in Johnson County. With that said, the overall funding stream and the system is inadequately funded. And I know that we'll talk a little bit more about that later tonight. As far as the mental health center itself, I have 4 primary clinical divisions: adult services, children and family services, addiction services, and then our emergency services. And that's really what makes up the core of Johnson County Mental Health Center. We've really tried to focus our efforts over the last 6 months to really take a close look at how we do our business. And really what I like to tell people is that we focused on 3 primary points. You call it the triple aim of healthcare is what many people refer to it as. But you're talking about access, quality care, and cost containment. Access meaning that people have access to the services that they need. In the time that I worked in community mental health, I never really understood why, when someone had the courage to call or ask for help, historically what mental health centers have done is said, well, we'll set you up with an intake and we'll see you in 3 weeks. Unfortunately, if the person needs help today, we're not able to get that to them. We're asking them to wait 3 weeks. Unfortunately, if the person needs medication, it can even be longer than that. And so the thing that I'm probably most proud of is the emphasis that we've put in immediate access. As of January of this year, we have implemented an open access model, meaning that when someone calls, we ask them what time we can expect them at the mental health center. So you can walk in and get same-day access for mental health services. Again, we'll assess the need, we'll determine who and where you can best be served. That may be with us, that may be with one of our community partners, but it's really about immediate access. Another piece of immediate access is really the collaboration that we've done with Rainbow Services, Inc., but even more importantly, it's the work that we've done with local law enforcement. And I'm also very proud of that as well. We now have 2 what we call co-responders. Those co-responders are actually staff of the mental health center. They're licensed clinical social workers that are actually assigned to the police departments. They wear a uniform, they drive a police car, they have a police radio, and whenever there is a dispatch call for the police that indicates that there may be some sort of behavioral health issue, they respond with the police. So it's immediate access on site with the police officer to develop a plan on how to best serve that individual. You combine that with what we call CIT, crisis intervention teams, which is training specifically designed for law enforcement officers. We have about 450 trained officers in Johnson County now. So anyone ought to be able to ask for a CIT officer in any community in Johnson County and be able to get one. Between co-responder CIT and Rainbow Services, Inc., we have the ability to provide immediate access to anyone in a mental health crisis. And those are the things that I'm most proud about within Johnson County. Challenges are, it gets back to funding. I think we are certainly inadequately funded at the mental health center. We when we look at the consequences of not adequately funding the mental health system, you're looking at increased hospitalizations, you're looking at increased use of ERs, which is costly. You're looking at increased incarceration, which we're trying to buff with the collaborative efforts that we've made with the police departments. And you're looking at increased suicide rate. The suicide rate in Johnson County is higher than it's ever been. It is continuing to rise. We were hopeful that we saw it level off in 2014, and it was a slight increase, but for the most part, we've seen what I would consider a kind of an epidemic increase in suicides within Johnson County. And so those are the consequences of not funding adequately the mental health system. And so I think we'll talk a little bit more about what that means. And I will just echo the importance of Medicaid expansion. For us, 60% of the adults that we serve are either inadequately insured or non-insured. So if we look at 60% of the people then becoming eligible for Medicaid, that's a huge infusion of new dollars into the mental health center. Jason said it's good for us. In my opinion, it's good for us, but it's also good for Kansans. It helps people get back to work. It helps people manage their illness so that they can live healthy and productive lives in the community. And it is a revenue generator, not necessarily a revenue user. It brings productivity in the workforce and all kinds of other opportunities. So I think that Medicaid expansion is one area. Not to take any of Kyle's thunder, and I'm not sure what he's going to talk about, but I'll just share that in the 19 years that I've been at Johnson County Mental Health Center, the last time that we saw a significant infusion of money into the mental health system specifically was in 2000 with Mental Health Initiative 2000. That's 15 years. Since about 2007, we've seen nothing but decreases. Decreases of a significant nature. And in the last 2 years, we haven't seen decreases. We've seen those funds stay level. But if you're aware of how businesses operate, it typically takes 3 to 5% each year for you to do business. And so staying consistent funding is actually, in essence, a 3 to 5% decrease. Now, I'm not complaining about level funding, but it gets back to the fact that the system itself is inadequately funded, and there are consequences for that. We served just under 8,700 people this year. In 2011, we served nearly 11,000, and that has a specific direct impact on our funding levels. In the last 2 years, I've lost 114 staff. So while I say that I have 340 FTEs, I used to be about 440, and that is a significant decrease. We are not even scratching the level of need that exists in our community here in Johnson County.
Thanks, Tim. Kyle?
No.
There, push the right button eventually. It's a little like the legislature. Again, I'm Kyle Kessler. I very much appreciate the opportunity to be here this evening. I always enjoy being in a Methodist church, having been raised a Methodist minister's kid. My dad would be delighted to know that at the age of 44 I might be able to actually behave in a Methodist church. But I think that Tim and Jason hit on some really great points, and I will tell you there are a lot of things going right in Johnson County. A couple of those people are to my right. They are really they're not just up-and-coming leaders, they've arrived. Having preceded or succeeded, I should say, people like Dalen Schmidt, and then David Wiebe, who was a fixture in mental health around the state of Kansas for years. Jason and Tim are certainly equipped to carry the banner far into the future in terms of innovation and implementation of, I think, terrific treatment-oriented practices. So I wanted to visit about a few things, and really some of that was to give you an idea of what the Kansas mental health system is in relation to Johnson County's system, and that's related to the 26 mental health centers. Tim has 25 peer organizations around the state, and we serve over 120,000 Kansans a year as a system with 4,500 employees. So relative size, Tim's centers serves about 9% of the overall number that we see around the state of Kansas. Those community mental health centers range from one county mental health centers like Johnson County or Wichita to out in northwest Kansas. I think they have 20 counties there, so very rural and in frontier. They don't just say rural and urban out in western Kansas. They say urban, rural, and frontier. And so I think that when we look at what we were hoping to see, what we expected to see in terms of advocacy and issues in Topeka that would be considered by the governor and the legislative branch, we knew the state budget was going to be an issue based on the tax policy that was passed. And so that, after many months of dipping revenues, we knew that there would not be a likely opportunity for growth or just trying to keep up, as Tim so eloquently mentioned. The other thing that we hoped that would be a big part of the conversation, which is just now heating up, is Medicaid expansion. They have 2 days of hearings in the House Health and Human Services Committee, and today the proponents were speaking. I believe I talked to one of the coordinators with the Kansas Hospital Association. They are the big promotional agency for Medicaid expansion, and they have been working on this tirelessly, I think, for about a year and a half. They had coordinated, including ours, about 125 pieces of testimony from supporting organizations. So how they were going to get through those today in 2 hours, I'm not completely sure. And tomorrow the opponents will speak, and there aren't nearly as many opponents, but it will be an important part to put together the votes. Obviously, I think there's a lot more support for Medicaid expansion in the House of Representatives than there is in the state Senate at this point. The governor has been indicating recently that his position on Medicaid expansion is softening. We do have a large, and it's not just in Johnson County, but around the state, the community mental health centers have a statutory mandate to serve anyone who comes through their doors and provide them with mental health treatment regardless of their ability to pay. So what that means is they are essentially the emergency rooms of the community mental health system, or the mental health system for the state. Other folks, and I've known private practitioners, and in fact my wife being one, and what goes along with trying to provide services and be able to bill Medicaid is providing access to services. And the mental health centers and a few other organizations have 24/7, 365-day operations. And those are not cheap, and they are not easy places to work. And one of the other things we had hoped to, you realize that there's what you hope to have happen in a legislative session, and then you have what actually happens. And so rarely, I've probably had, in about 15 years of working legislative sessions, I maybe have had 2 where those actually matched up. And they are strangely in times when there's not very much money and people's eyes are looking at something else like education. And so it's just kind of the way things work out. But when we were looking at what we hoped we would get a chance to talk about, it was the program that Jason and Tim and Randy Kallstrom at Wyandotte Mental Health Center in Kansas City, Kansas, have really collaborated extremely well on, which is the Rainbow Services initiative, and in trying to provide people with kind of what I characterize as an intermediate level of care, and so that they don't have to go to Osawatomie State Hospital or into incarceration or something like that. And so we've really evolved a great deal as a state and as a society. I think that Kansas has long been a national leader in the area of mental health, whether you look at our state hospital systems and how we were transitioning to community-based services away from the old institutional settings. You look at premier providers like the Menninger Clinic, and then again going back to the workforce shortage, trying to keep people and staffed, or trying to keep the community mental health centers and other providers staffed can be a real challenge. And in fact, I was visiting with a deputy secretary the other day at the Department for Health and Environment, and he said, you know, some of these comments you've made about the workforce shortage of psychiatrists in the state, he said, you know, you're actually on the money on that. He said, I was looking it up, and he said 58% of the psychiatrists in the state of Kansas are age 60 or over. That doesn't bode well for meeting our needs. And don't get me wrong, it was very validating for him to notice that I wasn't making it up. But, I mean, it was also something that some of these, and this was directly related to another issue which we hoped we would not deal with, but we ended up spending a good deal of time talking about Senate Bill 123, which was legislation that would repeal the exemption on mental health medications from prior authorization and preferred drug lists for persons on Medicaid. So the significance of that issue, it actually goes back to something that Tim was just saying. If people have to wait for medications, or if they have people disrupting what are successful medications, then they are more likely to end up in emergency rooms or in state mental health hospitals, or potentially involved with law enforcement and in jails. So we disagreed with the state's view on that, and the Senate ended up defeating that bill 25-15. And so that was not something that we envisioned that many votes for, but I would tell you, you do have some excellent legislators from Johnson County. Senator Kay Wolf voted against that bill. Senator Rob Wilson, Senator Greg Smith. On that bill, those three were all opposed to it. And then on the House side, certainly Representative Nancy Lusk and Representative Gallagher, Cindy Gallagher, Representative Perry, have all been very engaged in this conversation as well on the House side. And so I think that this is helpful that groups like yours get together and make yourselves aware of the issues so that you can share your feelings or views or ask questions of the candidates. It's one of the healthiest exercises in the democratic process, for sure. So then the other couple things, we really wanted to talk about health homes. Healthcare homes are really the future of healthcare in a lot of ways, especially for deep end populations, for people suffering from severe mental illness, and they are engaged in, or they have Medicaid as a payer source. But I even see potentially private insurance going this way. So you are encouraging organizations to keep people well rather than to treat them when they are sick. And so that is an innovative part that the administration supported and promoted, and it was part of the Affordable Care Act. So we've started that with severe mental illness, the health homes. I know, how many are you serving in health homes? Do you remember, Tim?
About 1,700.
Okay, so about 1,700, and that may be about the high number in the state for a community mental health center. Probably you and Wichita are really close.
Could you just explain what a health home is?
Yeah, and I'm going to do a good job deferring to Tim for the specifics of that. But I mean, it really is kind of next generation type healthcare. If you want to give an idea of your program.
So what we know is individuals who have serious mental illness die 25 years younger than the general population. And when you look at the reasons for that, in many cases it's because they don't take care of themselves in a preventative fashion. They smoke, they eat unhealthy, and they just live unhealthy lifestyles. One of the things over the years that I've seen is it was really difficult for me as a case manager to help encourage someone to even go and see a psychiatrist. And so once you're able to get someone to go see a psychiatrist, then saying, okay, now you also have to go see your primary care physician. It's like, well, I don't want to go to 2 doctors. So the whole notion of integrated healthcare is one of which you're looking at the whole person. Where we separated the body from the mind, I'm not quite sure where that ever happened. But it's really a bringing together a holistic view of an individual. And so when you talk about health homes, what you're talking about is an individual that can coordinate all those systems of care. So that you have a health, and here in Johnson County, we took a very different approach than many others in the state of Kansas. And one of the reasons that we were able to take a different approach is because we are part of county government. And so one of the things that we could do is either I could serve as the health home, Johnson County developmental supports could be the health home, or public health could be the health home. And what we decided was, why not partner all 3 of us together, because we all serve these individuals, and do it collaboratively. So what we have done is we've created a health home that, in essence, has created, and we've all put forth pieces of existing resources. And so the health home itself is actually what we call a care coordinator. And that care coordinator has access to the mental health system, to the the primary health system, as well as the substance abuse system, and they coordinate the care for all of those folks. So, for example, to give you a practical example, the health home coordinator is able to determine or see when a client of ours, mental health centers, has gone to the ER. And they can look at that and they can say, Joe Smith went to the ER last night and they were having some problems. They can call the case manager and say, were you aware that Joe was at the ER? You might want to follow up with him this week. It's all about making sure that the care is coordinated in such a way that we are meeting not only the mental health needs, but the physical health care needs, as well as the substance use needs. It does us no good to help someone recover from schizophrenia, which is a long road to recovery, and then for them to die of a heart attack within a year. So it's really an approach about how we can better serve in a holistic way individuals in the community. One thing I might just say also is that I'm really proud about is on April 1st, we will integrate healthcare. So I will have primary care physicians at the mental health center facility. So not only can an individual come and see their psychiatrist, they can also see their primary care physician. And that's a huge piece of integration. But that's
Thanks,
really
Tim.
quickly health homes.
A few more comments, Kyle, and then to Sharon.
Sure. Just briefly, then there was a House bill that was 2315 that had to do with licensing standards for service provider organizations like CMHCs, and this was something that was intended to be a cleanup bill after SRS, as I still refer to her as Representative Quigley, as she was mentioning, when it was split up into the DCF, and then part of it also went to KDHE a couple years ago, but then mental health and SUD treatment and the community developmental disability organizations and IDD programs also went to the Department for Aging and Disability Services. And so they did not have that as a clean split. And so when they tried to put together the language, they ended up treating pretty much all of the service providers the same. And so this was a mistake in terms of, I think, their approach, and they decided to shelve that bill. So that's been helpful. There's also Senate Bill 254, which has to do with BSRB, Behavioral Science Regulatory Board standards for like clinical marriage and family therapists and social workers and the other behavioral health professions. And so really, like, what I would tell you is in any given year, 3 of those things would make for a completely full year. so that you were working on crafting the best public policy possible and trying to get programs funded at the appropriate level. And I think I just counted eight things. So, I mean, it ends up being quite a chunk of issues. So I will go ahead and hand off to Sharon.
Okay. Thank you. Well, I'm Sharon Manson, and I'm very delighted to be here. I really appreciate this opportunity. I'm kind of looking at this through a little bit different eyes than my fellow panel members right here. I professionally am a special ed teacher and have worked for many years with students with emotional disturbances and mental illnesses, and had been out teaching in my career, had my master's degree, and then all of a sudden a much younger sister of mine became ill. We started seeing some strange things. And I'll tell you, switching from the professional to the personal was very difficult. And I kind of found that I did not have the knowledge and the skills that I needed to work with someone within my family that had a mental illness. Over the years, my sister has lived with me off and on. And I just kind of watched her kind of slowly deteriorate and things not going well and doing some very scary things that, the family was kind of concerned that she would live to see 21 years old. After several years of this, I kind of decided I needed to educate myself so that I could be able to help her. Because I decided that, I knew exactly what she needed to do, and if she would just listen to me and do it exactly the way I said it, everything would be fine. Well, it doesn't, she's an adult, and it just didn't work that way. Well, I happened to see, the time I decided, okay, I need to educate myself, saw a very tiny article in Sun newspaper, when we still had it, for of all things, a free 12-week course for people who had family members who are mentally ill. Oh, you cannot be, perfect timing. So I called and signed up, and that was my first introduction to NAMI, which is the National Alliance on Mental Illness. I am so grateful that I took that step, went in there. My first night in that class, I looked around because, even though I worked with some very wonderful people, I worked regularly with psychologists and social workers in the school setting. I was very careful what I said about what happened within my family. Because nobody had things this strange or this bizarre going on in their home life. Well, my first night of my family-to-family class, I sat in there with a group of other 20 people who were exactly like me, who had stories that were just as strange as mine, if not stranger. And it was probably the best thing I ever did. And I think through this class, I learned some very good coping skills for myself and some better ways to help my sister. And I say this has been probably a 30-year process with her, since she first became ill. And I'll say she is 45 years old today and doing quite well. So it does get better. But anyway, a little bit about NAMI. NAMI was first formed in 1979 around a kitchen table in St. Louis by a group of parents who decided, like me, that there had to be a better way and they wanted support for themselves. The original founding members there are affectionately known as the NAMI Mommies, right there, who kind of took control and were able to put together a very large grassroots organization that is dedicated to helping people who are affected by mental illness. Not only family members with people who have mental illness, but people with mental illnesses themselves. Our organization, our NAMI focuses on three things basically: education, advocacy, and support. As far as education goes, we do have some signature, we call them signature education programs that, and Family is one of them, that are just tremendous support for community members. We offer all of these classes are for free for anybody who needs them. not only do we have family to family, we have another one called peer to peer that is for people living with a mental illness. Teaches good, healthy living skills and crisis management skills also with them. We have another program called In Our Own Voice, which is kind of a speaker's bureau type thing. So any organization that would kind of like to hear from two people who are in recovery from mental illness, kind of their experiences, they've got a whole video that goes with it. It's very impressive. I've seen it a number of times, and everyone is different because the speakers change there, but that's a kind of our community awareness program there. A fairly new program for NAMI is called Basics, which is helping parents who have young school-age children who have a mental illness and helping them kind of deal with social services and school systems and writing IEPs and all those legal documents, that kind of fun stuff there with that. But, in a number of other programs, too. NAMI also focuses on advocacy. I know that just last week, NAMI, along with a lot of other organizations, took a part in Mental Health Advocacy Day, or met with their legislators in Topeka. The Mental Health Coalition does a very nice job of anybody who's willing to get up there and talk with their legislators, kind of informing you of the issues, giving you some fact sheets there to go talk with your legislators. And I've been able to do that a couple of times, and it's really a lot of fun right there. Support is our other focus right there. We do carry on regular twice a month support groups. We always have 2 of them going. We have one for family members and then one for people who live with a mental illness right there. And I think those have turned out to be very valuable for some people. I am fortunate enough that I get to lead one of those groups every month. And to be very honest, there are some nights where it's been a long day at work and I would rather be at home on the couch with the dog. But I go out there and somebody shows up who is in crisis. And unfortunately, usually the people find us the first time that they show up, they are in crisis. And it makes it all worthwhile. I'm very happy to be there then and very glad that I did that, and just extremely proud and happy of NAMI. I think some of our successes have been being able to carry on some of the support groups and the educational programs and being able to reach out to the public and help people who are in crisis with them. I think that's very exciting. I know Tim mentioned CIT programs, the training for police officers. I was fortunate enough to be involved in a criminal justice mental health intercept project a few years ago, which was fascinating. And with all these law enforcement people in various capacities, and then me sitting there as the lone kind of family voice member and all that, I was fascinated with how knowledgeable law enforcement is about mental illness and how much they wanted to reach out and help. And I think that's very important. I think as far as some of the challenges that we're facing, I know NAMI very much is in support of expanding Medicaid. I think some of the people that I see coming through our support groups that are very upset is their family members kind of need the services at the right time. And unfortunately, a lot of our family members end up in either hospitals or in jails. And neither one of them are very cost effective or really the right way to go to treat somebody with mental illness. So, we're very much right now advocating for that. And I know that just a few weeks ago we did hear that the state of Kansas has decided not to renew NAMI Kansas's grant for the following year, which could be a very devastating blow for us. And now what kills me is it's I think in the whole scheme of things, not a lot of money, and this pays for our only 3 paid staff members in Topeka, who are the glue that hold together all of the local affiliates around the state and hold together all of the volunteers that are able to, implement the support groups and the programs. So I think we did hear today that I think that it's looking good. There was a proviso that was put in somewhere that somebody's advocating for maintaining our funding from current funds somewhere. So we're hoping about all of that. But NAMI likes to be very much in partnership with some of the organizations around the state, Johnson County Mental Health especially right there. And I know working with them and other organizations, we're kind of able to get our loved ones, our family members, the support and the care that they need.
Thank you, Sharon. I'd welcome any questions if anybody has them and wants to turn them into Sandy. I'll get us started with a couple here. In the 1990s, state grants helped support community health, mental health centers and that treated those people without health insurance. But those grants were reduced by at least 50% in 2008 and really haven't come back. How do the uninsured and underinsured get help today? And does the Affordable Care Act cover mental health services? How does that impact you?
We're in the process of developing data or an estimate of what the total amount of uncompensated care across the system is. I believe it's around 50% of our overall funding sources come from a wide variety of different places that range from Medicaid to private insurance, private development, in Johnson County Mental Health, which is in fact, I guess you have a small foundation that you guys have as well, don't you? And which is unique for a government-affiliated mental health center, of which there are, I think, 3 in the state, and Tim has one of those. But there are a lot of freezes on, I think, in the mental health system, and so you do lose employees to other better-paying positions a lot. So, and workforce retention is a huge issue. I think that on Medicaid expansion, this would be significantly helpful depending on what the program looks like. In visiting with my counterpart in the state of Indiana, the Medicaid expansion program, or the model that Kansas is looking at, is like the Indiana model, which is more kind of a premium assistance type program. And so when asking my counterpart in Indiana what he thought about Medicaid expansion, he said it was better than nothing. So I don't know if I'd call that a ringing endorsement, but it's better than nothing. So was that and part of that grant reduction, as I recall, also had to do with with increasing some of the Medicaid expenses, but then that only went so far because of the number of people, or Medicaid rates, I should say. But then when you don't have people who are eligible for Medicaid, then there's a real cap on how that's going to affect the overall service delivery and the revenues to the system.
Does Medicaid cover mental health services
It
pretty
does.
well,
Yeah, pretty well. Some codes probably maybe are there maybe some of them that reimburse at much higher rates or portion ratios than others.
In general, Medicaid actually has a much better payment for mental health services than most actual private insurances do. So in that case, it really is beneficial. I think one thing that would be important to just tag on is that in 1990, with mental health reform and shifting those community dollars from the state institutions to community mental health centers, the idea was really to reduce the number of individuals in the state hospital and move those funds into the community so that those individuals could be supported in the community. And that's a good plan. It's worked for the most part. The biggest issue is that then when you start cutting, and you said 50%, I think ours is closer to 70% since 2007. And so when you look at 70% of the funds being cut, and still individuals not qualifying for Medicaid, then you have this huge gap of individuals that don't have insurance, and there's really no way to pay. Now, fortunately in Johnson County, we get a substantial amount of money from the county. And that allows us to be able to pay and provide services for that uninsured population probably much easier than some of the other mental health centers across the state, but it's still a challenge for us. The last thing I might say in particular about the payment structure is that when we look at Medicaid and the way that it's set up, is that one of the things that we used to think about in the 1990s was that when people had mental illnesses, and as a case manager, my job was to help maintain people in the community. And I was cool with that. I'm going to help maintain people in the community. What I learned quickly is that it's not about maintaining. It's about helping people become viable and active citizens in the cities and communities that they want to live, that recovery from mental illness is possible. Prevention, we now know prevention of major mental illness is possible. And so when you start to talk about helping people recover, unfortunately the system that helps us pay for that does not promote that. Case in point, I have an individual who suffers from schizophrenia, and I work with them to develop the skills to be able to manage the symptoms of schizophrenia. They take their medication, they practice their techniques to reduce the voices, and so they go back and they go to school and they get a job. And immediately after they get the job, they make too much money to qualify for Medicaid, even though it's just a part-time job. So then what happens? They lose their Medicaid, they can't get their medications, they can no longer come to the mental health center because they don't want to incur a bill because now they've paid for service, and it's a proud issue. And so they decompensate, lose their job, lose everything that we worked for, and get back to the basic. So when I look at Medicaid expansion, it really provides us an opportunity for people to build assets, to build the assets that are needed to sustain their lives and their livelihood. And so I think we have to think about it from more of that perspective as well.
Just one piece that I'd like to add to that. You asked about the Affordable Care Act, and I can't speak to mental health per se. I can't speak to some of those things that Kyle and Tim have talked about. But one of the things that we are finding and we're seeing more and more is with the CARE Act and there being the opportunity to folks to go out on the exchange and sign up for insurance, or families going out on the exchange and helping their loved ones sign up for insurance. Now we're seeing some of those folks go access mental health services, they go access acute psychiatric services, and so we have insurance companies that are becoming more and more interested in the things that Tim is talking about in terms of treating the whole person. They're coming out and they're saying, whoa, this is really expensive stuff that you all do. We're not just treating the working well anymore, we're treating the very chronically ill individual, and we're doing it from the private side of things. So programs like Blue Cross and Blue Shield are coming out and saying, how can we go access some of these community services that the mental health center is offering, that substance abuse services are offering, so that we can treat people more cheaply, save a little money on the back end and keep premiums down. So it's one of the byproducts of ACA is, again, it's some creative thinking, because the insurance companies are getting hit pretty deep in some cases. We're seeing folks that are going into psychiatric units for 15, 20 days, and that isn't cheap on the private side of things. But if they could fund something that Tim provides or that our agency provides for a couple of $1,000s, they save quite a bit of money. So it's a byproduct of that.
So it's kind of forcing people to look at prevention. Yeah.
Absolutely.
Yeah. Okay, Jason, here's one for you. What's the best way to access RADAC for people over 70, or is there any difference in access?
There would be no difference in accessing for somebody over 70. Our only criteria, it doesn't matter what age you are, is being able to participate in your own services. If you can participate in your own services, then it's not a problem, whether you're 14 years old or 75 years old. So.
And here's another. What's the role for AA in alcohol recovery?
AA plays a gigantic role in alcohol recovery, and really what it does, there's sort of a tongue-in-cheek statement out there that the best treatment there is out there is AA. AA is not treatment in any way, shape, or form. AA is a completely community-based support group that allows people to mentor and guide and help people along the road to recovery. Really, what the services we provide are the acute support to what AA provides to somebody that's walking that road. And so we encourage anybody that is connected to our services, alcohol users, substance users, to get connected to those 12-step groups, however they may work. And not only 12-step groups, but other places like Celebrate Recovery, which is out there, which is a more faith-based type of support system. But AA plays a massive role. You have to connect people to those supports in the communities, because our service is going to end. And in someone's lifetime, our service is a really short little blip in time. We hope that we can impact, but it's those connections that we encourage through our case management, through our outreach, that we hope will have the lasting effect.
Here's a little bit out of the box question. What is your perspective on legalization of current illegal drugs for medical and recreational use? Is the war on drugs working?
Well, load it right up. I will speak for our agency. Tim's agency may have a completely different perspective on this. We are anti-legalizing illegal substances. We don't see how that increases public health. We don't see how it decreases the amount of work that we do or the cost to systems that there are. Now, would I agree with decriminalizing some of those things? Yeah, I would. Somebody that gets picked up for a certain amount of marijuana in their pocket and gets charged as a felon doesn't seem very productive to me. And so I look at it along those lines as opposed to complete legalization. It's very attractive when you're a legislator and your state's in a financial crunch. Very, very attractive. But the cost on the back end is something yet to be determined. And we have some guides along the way. So our hope is that this really doesn't come strongly to the forefront until we see what those impacts are in states like Colorado and Oregon. Because they're seeing a pretty significant impact on the back end. Employers are already saying they're having a really hard time finding people that can come to work that don't have marijuana in their system, and they're in jobs that you can't be high to do them. I mean, it's a safety risk for the organization. So, like I said, Tim may have a whole different perspective on that. I don't know, but
I do not.
Short and sweet, like that.
The one piece that I might just add is that I think that the important thing to think about is we're really talking about prevention. And so those individuals that have a serious mental illness, we can help move towards recovery, but we can prevent major mental illnesses from happening. And it's working with young people to develop how to help them develop the skills to be resilient and to make good choices, and how to manage stress. When you talk about youngsters and their brains and introducing chemicals, nothing good can come from that. And what we know is right now, alcohol in Johnson County specifically, the average age of first use is 13 years old in Johnson County. Average age of first use in Johnson County is 13 years old, and that's for alcohol. You introduce legal marijuana, and I guarantee you they're going to be smoking marijuana. And I just can't say enough about how young people's brains and what the chemical reactions can be that would not necessarily prevent mental illnesses, but I would suggest may actually increase the propensity for individuals to experience a mental illness.
Sharon, would you like to talk a little bit about some of the barriers you think people experience in trying to access mental health care?
Yes.
Thank you.
I think, and just a little detour here before we
Sure.
answer all that. I think, talking with many, many family members, I think our first kind of barrier, if you want to call it this, is having your loved one realize that they need help in there and getting them to agree to go and get help. So barrier in a way, right there. I think then that another issue is the fact that if things spiral out of control and the family member gets arrested, then you've got the criminal justice system to deal with in there. And then that, in a way, can slow down getting the right treatment at the right time for them. So, it just kind of adds another layer on there. So, I think, too, that just general knowledge of the public about mental illness and what to do and where to go, I think, is very important. Because a lot of, and I was one of them, when this first hits the family, you'd have no idea what to go, who to turn to, right there. And I think if we just had better knowledge, in general in the public about what mental illness is, and get rid of some of the stigma to it, which is a whole nother topic there, that I think that people would get the help they need and a little bit quicker.
Thank you. Here's one. I've read studies that say well over 50% of inmates in state prisons suffer from some kind of mental illness. A Nightline TV show showed hundreds of inmates in an Illinois prison standing in line to get their meds. About the time they get to the front of the line, it's almost time to get in line again for the next dose. What's your knowledge of the mental health services provided in Kansas prisons? Are meds used to treat patients or to control patients? To what extent is therapy used as treatment in lieu of or instead of medication? Are psychiatrists and psychologists on staff at our prisons? So, anybody know about mental health treatment in prisons?
Tim does.
I can lead off very briefly just by saying Secretary Roberts, who's the Secretary of the Department of Corrections in Kansas, has said regularly that he has the largest mental health facilities in the state of Kansas. And even the Cook County Jail, I think that the question refers to, for 10 years, you've heard speakers say the largest mental health facility in the country is the Cook County Jail in Chicago, or it'd be the LA County Jail in California, depending on who most recently added beds. So, I mean, it is a substantial issue, and psychiatric treatment specifically, I would suspect is pretty few and is pretty rare. And Tim will have a really valuable perspective on this, just because he works so closely with I think Sheriff Denning and the county jail. So I don't know. And when you say treatment versus control, those are really interconnected. I mean, they really, when you listen to clinicians talk about that, you hope that it's treatment so that it's connected with therapy. I've seen studies, even the Kansas Health Foundation did one a few years ago, that showed psychotropic or antipsychotic medications given to kids oftentimes were by family physicians, and they would just give a pill, but they didn't connect them to a community mental health center or another therapy or treatment provider. That's similar to giving someone pain medication and not telling them to go see the physical therapist if they have a torn rotator cuff. It really needs, I think, and again, Tim's a clinician, but hopefully it will be a joined effort when you look at medication plus therapy.
So from my perspective, and we do hear that the largest mental health institution in Johnson County is the jail, the county jail, and I agree that a consequence for a underfunded system is that more people who have mental illness end up in jail. I think there has to be a delineation, though, between the number of people that take psychotropic medications or take some sort of medication for mental health issues versus the individuals in the jail that have a severe mental illness. If I was in prison, I would be depressed, and I probably could benefit from being on an antidepressant. Does that mean that I'm seriously mentally ill? No. So if you only look at individuals that are taking psychotropic medications, I think you get a misrepresentation of the total number. I think a better descriptor and a better number to look at is how many of those individuals have a serious mental illness. And we have a clear definition as what we mean by a serious mental illness. The federal definition is very clear. So I often like to ask that specific question when I hear that, because I am sure that there are a large number of people that need to take antipsychotic medications or not antipsychotic, but psychotropic medications to help sleep, for depression, all kinds of things. But to me, there's a difference. I think the big challenge within prisons and in county jails gets back to something that Kyle talked about, and that's preferred drug lists. In Kansas, we were able to kind of fend that off for now in regards to having mental health drugs be protected. But in institutions like jails, whether that be prisons or jails, in many cases there are preferred drug lists. And what happens there is that people that have been shown to do well on a certain medication will be taken off that medication while in the institution and placed on a lower or a less expensive drug. And I think that is a huge issue that occurs within our prison and our jail system is that preferred drug list. So while there are entities that would like to promote the preferred drug lists in the community, I would be a proponent of eliminating them altogether and allow doctors to prescribe what we feel or what they feel are the best. Now, I understand that the issues is that some people feel like we may be drugging people to maintain behavior, or we may be over-medicating children. Those are prescribing practices. And those are what we need to focus on, is specific prescribing practices by physicians. And there's ways to be able to track that. And so focusing on how we can monitor prescribing practices and adapt those or monitor those is the way to address the issue, not taking away the ability for a psychiatrist or prescriber to prescribe the best medication for the best result for each individual client.
Thank you. I want to get in one more question, and then I'll let you make final comments. You all have alluded to funding cuts. Tell us one specific thing in your area that has suffered from a funding cut.
For me, it's a loss of 114 staff, caseloads that at one time were 20 to 22 people, now being 30 for case managers, for clinicians, caseloads of being anywhere between 80 to 100 when they used to be 40 to 50.
I think from the subsidy side, you're looking at no increases in funding for some things. We have had some funding cuts in the past that we're fearful that might happen again, that have reduced services. That what we found is when we've been able to work with individuals using the funds that we receive, we we were able to show very significant cost savings to the communities that we were working in. When the funding was erased, the increased cost of the community immediately went up, and we were able to track those things. So that's where our fear lies in that, and anticipating what might be coming down the pike, and knowing that a lot of agencies down in Topeka are probably going to be asked to take specific cuts to their line item budgets and how that's going to affect us. So,
How much of your funding comes from the state?
quite a bit of it. Over 80% of it comes from different state pieces, whether it's KDOC or KDADS or DCF or any of those. So it feels diverse, but at the same time, it comes from different departments down there.
You've had a pretty steady funding stream with alcohol tax, is that?
Yeah.
Yeah.
Yeah. We'd like to not see that go away.
Yeah. Kyle, anything funding-wise?
From a funding standpoint, right now we would have our attention really focused on making sure that the Senate releases its hold on the chronic conditions health home funding. Chronic conditions, so for persons who suffer from asthma or diabetes, and many of them also have mental illness. And so our system had been looking at, or had geared up to provide those health home services. The House still has it in their budget, but the Senate has said that they don't want to spend any more money on it until they know what kind of outcomes will be associated with the severe mental illness health care homes. So hopefully we can still get that program off the ground yet this year.
Thanks. Sharon, you had mentioned NAMI just having 3 staff, I think you said.
Yes.
If you don't get your money, do you know what that impact
These 3 staff members will no longer be staff members.
is? Your only funding from the state?
That is not the only funding, but that is a big portion of it. So that's going to be kind of the major portion of the budget, so that we will not be able to maintain them at the salaries that we have right now.
So you're
yeah.
mainly a volunteer organization,
Yes,
and you
we are
have quite a...
mainly a volunteer organization, yes.
Okay. Well, I want to give you a chance. If we haven't covered something that you wanted to cover, if you don't have anything like that, tell me if you had a magic wand, what you would do to change mental health services in Johnson County.
Well, I'll start because why not? If there was a magic wand that I had, it would be an increase in integrated services. And Tim talked about that a little bit. I talked about it from a rainbow services perspective, and being able to provide that recovery-oriented systems approach to care, whether it's from a mental health perspective, physical health perspective, or substance abuse perspective. You know, our agency was built on opportunity and giving people the opportunity when they need it, as they need it, you know, when they decide to show up, no matter how many times they decide to show up. And I don't ever want to see that be limited by whether it's funding, whether it's philosophy, or whatever it might be. That's our goal, is to be able to provide opportunity for people to make positive change and healthy change in their lives, if they so choose to do that. And being able to do that is a pretty proud moment for our agency in Johnson County and in all of the other systems that we're in. And so therein lies the magic wand for us.
Okay. Tim?
For us, the magic one, I think, would be to see a Medicaid expansion actually happen. And then 2, within Johnson County specifically, there are specific consequences for some of the tax policies that have been enacted last year and that will drastically impact the county budget. And if the county budget is significantly impacted, which we know it will be in 2016, it was last year, that means that we'll also experience cuts from the county's perspective. So if I had a magic wand, I'd say Medicaid expansion and a mill tax levy increase by our county commissioners to ensure that we didn't have any further cuts within the mental health center or other human services within the county. With all that said, I do believe this is an opportunity for the mental health center to reevaluate itself. I do think it puts pressure on us to look outside the box, to look for partners, and so in my opinion, it is an exciting time. There's challenges, but we can also view those as opportunities.
Thanks, Tim. Kyle?
I think that what Tim and Jason have both said about integrated care would be my magic wand item. And one, again, piggybacking on something else that Tim said, when we look at the integrated health, which is really focusing on all parts of a person, and when people think about the history of mental health and how far we've come, and the stigma that was attached to mental health treatment for so long, for some reason we really got into a habit of treating the brain differently than we did the heart, lungs, kidneys. Brain's really important, and so I mean I think that when we talk about mental health, we're talking about brain health, brain or brain illness as things go. So I those conversations and even the ones relating to mental health medication, we think we're getting pretty close to having kind of some compromise language worked out, where the state would just establish a mental health medications advisory committee that would include several psychiatrists, a couple pharmacists, a family practice doc, and a nurse practitioner. So really the experts in prescribing practices can look at some of the other, maybe some unsafe practices from around the state and evaluate whether or not policy changes need to be made. But they could then call in front of them patients, pharmaceutical companies, managed care organizations, or other experts, family members of patients, and that can make good public policy, and I think put us maybe a step ahead as we try and compete with Missouri, because Missouri is doing some great things from an integrated care standpoint.
Sharon?
Okay. Well, there's not much I can add to all that. I think definitely my number one magic wand item would be Medicaid expansion. I think that would cover more people with insurance. It would allow them to get the help that they need, both physical and mental health care, which is only going to improve their lives. And I think, in the larger perspective, it's just going to help all of us keep down healthcare costs, all in the long run, altogether. So I think, to me, it's the only logical, fair thing to do is go for Medicaid expansion.
Thank you. Would you help me thank our panel for a very informative evening? And I want to thank you for coming out tonight.